Welcome to the deep dive. We've got your revision notes on diverticular disease right here, and we're going to really dig into them for you.
Yeah, think of this as us walking you through it, making sure all the key stuff from your notes actually sticks for your revision.
Exactly. So our mission today is to take these notes and make them super clear, super
We'll
memorable.
cover the definition, what causes it, the etiology, the risks, how it actually happens, the pathophysiology.
And importantly, what else it might look like, those differentials.
Yeah.
Plus, who gets it, how it shows up.
The clinical features, investigations, how it's managed, the prognosis, and potential problems or complications.
Right, let's jump straight in. Definition first. What exactly is diverticular disease?
Okay, so picture the colon and the large bowel. Diverticular disease involves these small pouches, they're called diverticula, poking outwards from the colon lining.
Like little weak spots bulging out.
Precisely. Think of it like that.
Mm-hmm.
And the most common place for these is the sigmoid colon, that last S-shaped bit.
Right.
Yeah, about 85% of cases are there. But you can get them in the ascending colon too.
Okay, but just having the pouches isn't always the issue, is it?
That's a really key point for your revision. If you just have the pouches, no inflammation, no symptoms, that's diverticulosis.
Osis. Got it.
Then, if those pouches start causing symptoms, pain, bloating, whatever, that's diverticular disease.
Okay, disease means symptoms.
And then if those diverticula get inflamed or infected, maybe with fever, high heart rate, that kind of thing, that's diverticulitis.
Itis inflammation. Simple.
Exactly.
Mhm.
Osis, disease, itis. Easy way to remember the spectrum.
Perfect. So what causes these pouches to form in the first place? The etiology.
Well, it's thought to be a mix of things, really. Age plays a part. The colon wall changes as we get older. Then there's increased pressure inside the colon itself.
And diet. I remember reading about fiber.
Absolutely. A low-fiber diet is a major factor. Less fiber means, well, harder stools, basically. So the colon has to squeeze harder to push things along, increasing that internal pressure. And over time, that pressure finds the weak spots.
Makes sense. Are there other things that contribute?
Yeah, definitely. Things like obesity, smoking, and not getting much exercise, like a sedentary lifestyle, they're all linked as well. They seem to add to the strain or affect colon health.
So linking that to risk factors then.
Yeah.
Who should be most aware of this?
The big ones are age being over 50 is a major risk factor, and that low-fiber diet we just talked about. Those are key.
What about younger people? You said it's rare under 40, but does it happen?
It does, and interestingly, in people under 50 who develop it, obesity seems to be a particularly strong risk factor.
And are there specific risks for getting the complicated version, like diverticulitis?
Yes, good question. For complicated disease, the risk factors include things like ongoing smoking, regular use of NSAIDs, nonsteroidal anti-inflammatories, or even paracetamol sometimes.
Right.
Plus, continuing with a low-fiber diet, and again, obesity is right up there. These seem to increase the chance of inflammation or other problems.
Okay, so let's get into the mechanism a bit more, the pathophysiology. How do those pouches actually form?
It really comes back to that increased pressure inside the colon. Imagine constantly pushing against the walls.
Yeah.
Over time, in areas where the muscle layer is naturally a bit weaker, often where blood vessels penetrate, the inner lining can bulge outwards through that weak spot.
Creating the pouch.
Exactly. And the low fiber intake contributes because, as we said, harder stools mean more straining, more pressure needed for bowel movements, which just exacerbates the process.
And diverticulitis, the inflammation part, how does that start?
So diverticulitis happens when one or more of those little pouches gets inflamed or infected. Often, a tiny bit of stool, what we call a fecalith, or bacteria, gets trapped in the neck of the diverticulum.
Like blocking the
Pretty much. And that blockage leads to inflammation, sometimes infection, causing the pain, fever, and other symptoms we associate with diverticulitis. It's like a little pocket getting irritated and infected.
Okay, so someone comes in with lower abdominal pain, maybe bowel changes, it could be diverticular disease, but what else might be going on? What are the key differentials for revision?
Yes, crucial point. There's quite a list.
Yeah.
Irritable bowel syndrome, IBS, is a
Mhm.
big one. Lots of overlapping symptoms like pain and altered bowel habits.
Right, IBS.
Then you've got inflammatory bowel disease, so Crohn's or ulcerative colitis.
Mm-hmm.
Also simple gut infections, gastroenteritis, colon polyps need considering.
And the really serious one?
Colorectal cancer, absolutely. Because the symptoms can mimic each other, ruling out cancer is always a priority.
Anything else on that differential list?
Yeah, other things causing acute abdominal pain, maybe appendicitis, although the location's often different. Ischemic colitis, where blood flow to the colon is reduced, can present similarly. And especially in female patients, you have to consider gynecological causes. Things like a ruptured ovarian cyst, ovarian torsion, or even an ectopic pregnancy could cause lower abdominal pain.
Wow. Okay. So quite a broad differential to keep in mind. How common actually is diverticular disease, say, here in the UK, epidemiology-wise?
It's very common in Western countries, definitely including the UK, and the key trend is it increases dramatically with age.
Right. You mentioned over 50s.
Yeah, it's estimated maybe around half, 50% of adults over 50 in the UK have diverticulosis, so diverticulosis.
Just the pouches.
Exactly. Remember, diverticulosis is much more common than diverticulitis. And it's pretty rare to see it in anyone under 40, so that 50% over 50 is a good stat to remember.
Okay. Good anchor point. So how does it actually present? What are the clinical features, the signs and symptoms we need to spot?
It can be quite varied. A classic symptom is abdominal pain, often, but not always, on the left side.
Left lower quadrant, typically.
Typically, yes. Patients might also complain of bloating, maybe changes in their bowel habits. Constipation is common, but sometimes diarrhea too. And increased wind, flatulence.
What about bleeding?
Rectal bleeding can happen. It might be passage of obvious blood, maybe clots. Sometimes people feel an urge to go to the toilet right after passing blood.
And if it progresses to diverticulitis, what changes? What are the red flags?
With diverticulitis, you often start seeing more systemic signs. So fever, maybe chills, feeling sick, nausea, vomiting, and losing your appetite.
And the pain.
The pain usually becomes more significant, often worse after eating, though sometimes passing wind or stool can offer temporary relief. And in rare, complicated cases, you might get unusual symptoms if a fistula forms.
A fistula, like a connection.
Yeah, an abnormal tunnel, say between the colon and the bladder,
Yeah.
a colovesical fistula causing air or stool in the urine, or to the vagina, colovaginal, leading to recurrent infections or discharge. Those are rare but important complications.
Okay, let's try and nail down the presentation for revision. Uncomplicated disease versus diverticulitis versus bleeding. How do they differ?
Right, uncomplicated diverticular disease, because
Yeah.
often it's found by chance, incidentally.
Mm-hmm.
If symptomatic, it's usually that nonspecific lower abdominal pain, often left-sided, maybe intermittent, linked to eating or bowel movements.
And maybe some bloating.
Yeah, possibly bloating, constipation, maybe occasional bleeding. On examination, you might just find mild tenderness or perhaps a bit of fullness in that left lower quadrant. Pretty nonspecific, really.
Okay, then diverticulitis.
That's usually more acute, more severe. The pain is typically sharper, more constant. Again, usually left lower quadrant. Though remember the caveat about right-sided pain in some Asian patients.
Got it.
You'll likely see changes in bowel habit, plus those systemic signs, fever, tachycardia, maybe anorexia, nausea, vomiting. Examination usually shows definite localized tenderness.
Could you feel anything?
Sometimes, yeah, palpable mass if there's an abscess, bowel sounds might be reduced, and a rectal exam could show tenderness or a mass if it's a low pelvic abscess. The big worry here is complications. Abscess, perforation, obstruction.
And diverticular bleeding, how does that present?
That's often quite dramatic. It's a common cause of lower GI bleeds. Usually it's abrupt, painless, and involves passing a fairly large amount of bright red or maybe maroon-colored blood or clots.
Not usually dark, tarry stools.
Melena is less common, no. The bleeding often stops on its own, spontaneously, and this is important, it can definitely recur.
Okay, so someone presents with these symptoms. How do we investigate? What tests are key?
We start with blood tests, usually, looking at inflammatory markers like CRP and white blood cell count WCC. They'd likely be up if there's inflammation or an abscess.
Anything else in the bloods?
A full blood count, FDC, might show raised platelets, a sign of inflammation, or maybe anemia if there's been significant bleeding. And checking urea and electrolytes is important, especially if you suspect complications, to assess kidney function and hydration.
And maybe rule out other things.
Yeah, stool analysis can be useful sometimes to rule out infectious causes of diarrhea or colitis.
What about imaging? That must be crucial.
Absolutely critical, especially for diagnosis and looking for complications. A CP scan, particularly with IV contrast, if the inflammatory markers are raised, is really the investigation of choice.
Why CT?
It's great for visualizing the diverticula, the colon wall thickness, any surrounding inflammation, and spotting complications like abscesses or perforations.
Are there alternatives?
MRI can be used if CT is contraindicated. Ultrasound might be helpful in some situations, perhaps as an initial test. And sometimes, if CT isn't feasible, a barium contrast enema might be considered, though it's used less now.
What about if you suspect a fistula, like to the bladder?
For those, you might need more specialized tests, like a cystoscopy looking inside the bladder or a cystogram, maybe using contrast or dye like methylene blue to try and show the connection.
And getting a direct look inside the bowel with scopes?
Yeah, endoscopic procedures are really important. Colonoscopy lets you see the whole colon, confirm the diverticula are there, and, crucially, rule out other things like polyps or cancer. Biopsies can be taken too.
When would you use that?
Often done after an acute episode of diverticulitis has settled to exclude underlying malignancy, or sometimes electively. For acute rectal bleeding, a flexible sigmoidoscopy, just looking at the lower part, might be the first step to find the source.
Any other, maybe less common investigations?
If bleeding is ongoing and you can't find the source with colonoscopy, you might move to nuclear scintigraphy or angiography. These can help pinpoint bleeding and sometimes even treat it, but they're more invasive.
So the overall aims are confirm the diagnosis, rule out the nasty stuff, and check for complications.
Exactly. Confirm, exclude, assess severity. That's the goal of investigations.
Okay, diagnosis made. Let's talk management. How do we treat diverticular disease?
The approach depends on the presentation, really, but the general aims are relieving symptoms, preventing complications, and just promoting good colon health.
So lifestyle stuff first.
Often, yes. Dietary changes are key, gradually increasing fiber intake, fruits, veg, whole grains. Staying well hydrated is important too.
What about those old myths about avoiding nuts and seeds?
Yeah, current advice suggests that's generally not necessary for most people. No need to avoid seeds, nuts, popcorn, or fruit skins unless they specifically cause symptoms for that individual.
And medications?
For pain, simple paracetamol is usually best. Antispasmodics might help with cramping for some, but generally you want to avoid NSAIDs and long-term opioids in uncomplicated disease as they could potentially worsen things or mask problems.
When does surgery come into play?
Surgery is usually reserved for recurrent, severe episodes of diverticulitis, or if complications develop like a perforation, abscess, fistula, or obstruction, or if symptoms just don't settle with medical management, and regular follow-up is important.
And what about emergency management? When do you need urgent intervention?
That's for the serious complications. So, a perforation leading to peritonitis that needs surgery fast, a fistula causing significant symptoms, a complete bowel obstruction, or major uncontrolled hemorrhage, those are surgical emergencies.
Let's focus on the prescribing side for revision. How does that differ?
Okay. If someone just has asymptomatic diverticulosis found incidentally, no treatment needed.
Simple enough.
If they have symptomatic uncomplicated diverticular disease, so pain, bloating, but no inflammation signs, and boosting dietary fiber hasn't worked, you might try a bulk-forming laxative like its bagula husk.
And for acute diverticulitis?
That needs proper management. Pain relief, often starting with paracetamol and moving up the WHO ladder if needed. And antibiotics are usually given broad spectrum, covering the likely gut bacteria, gram-negatives, and anaerobes. Often oral antibiotics initially if it's mild.
When would you admit someone to hospital?
Hospital admission is usually needed if they have signs of sepsis like fever, high white cells, severe pain, can't tolerate fluids, or if they don't improve after, say, 72 hours of oral antibiotics at home.
What about non-prescribing management?
Well, for complicated diverticulitis perforation, large abscess, fistula, obstruction surgery is often the mainstay, alongside the supportive care like antibiotics and analgesia.
And for acute bleeding?
If someone comes in with acute PR bleeding from diverticula, the first line is usually trying to stop it endoscopically during a colonoscopy. If that fails, interventional radiology might try angiographic embolization, blocking the bleeding vessel. Surgery is usually the last resort if bleeding continues despite those.
Can we quickly cover managing specific complications, say an abscess?
Sure. Small abscesses, maybe under 3 centimeters, might respond to antibiotics alone. Larger ones usually need draining, often done percutaneously by radiologists using CT guidance. Sometimes surgery is needed.
Fistulas.
Fistulas, like colovesical or colovaginal, generally need surgical resection of the affected bowel segment and repair of the connection.
Obstruction.
An obstruction might settle as the inflammation reduces with antibiotics, but some patients will need surgery to remove the narrowed section, or possibly endoscopic balloon dilation in some cases.
And hemorrhage again.
If bleeding persists or recurs after initial measures, options include repeating endoscopy, considering vasopressin infusion or embolization via angiography, or ultimately surgery to resect the bleeding segment if all else fails. Of course, resuscitation with fluids and blood products is vital initially.
When should we be referring patients to specialists?
Definitely refer immediately if you suspect complicated diverticulitis, signs of perforation, sepsis, large abscess. Also, refer if the symptoms suggest colitis, like IBD, or, very importantly, if there's any suspicion of colorectal cancer, they need to go down the urgent cancer referral pathway.
Right. Looking at the bigger picture, what's the prognosis like for someone with diverticular disease?
Generally, it's pretty good. Most people with diverticulosis, maybe 75%, never get symptoms.
That's reassuring.
Yeah. And lifestyle changes can really help prevent progression or complications.
Yeah.
When acute diverticulitis does happen, it's usually very treatable with antibiotics.
But it can recur.
It can, yes. And recurrent episodes or complications might eventually lead to needing surgery. Interestingly, most complications actually occur with the very first attack of diverticulitis.
Is it a dangerous condition overall?
While most do well, there is some associated morbidity and mortality, mainly linked to the complications of diverticulitis or major bleeding, perhaps affecting 10–20% of those who develop symptoms or complications. But overall, for the majority, the outlook is favorable, and recent evidence kind of challenges the old idea that younger patients always do worse.
So regular checkups are still important.
Definitely. Good follow-up helps manage things long-term.
And just to recap on prevention, what are the key strategies people can adopt?
Number one is dietary fiber. Lots of fruits, vegetables, whole grains, though its benefit might lessen once symptoms have already started.
What else?
Regular exercise, maintaining a healthy weight, and if you smoke, quitting is definitely advisable.
Okay. Finally, could you just quickly list the main complications we need to remember?
Sure. Key complications are abscess formation, peritonitis, if a diverticulum perforates, intestinal obstruction, usually from scarring, fistula formation connecting the colon to bladder, vagina, or elsewhere,
Then bleeding.
hemorrhage, significant bleeding. And although rare, some studies suggest a possible long-term link with colorectal cancer risk. But that's complex. Plus, chronic issues like strictures or ongoing inflammation from recurrent diverticulitis.
Excellent. That's been a really comprehensive run-through of diverticular disease, hitting all the key points from those revision notes. Hopefully that's made it all much clearer for you listening.
Absolutely. So remember the key definitions. Toidnosis, disease, Itis, think low fiber, high pressure. Know those differentials, especially ruling out cancer. CT is your friend for diagnosis and complications. And understand the management steps from diet right through to surgery for complications.
For more detailed resources, practice questions, and to really test your knowledge for the MSRA, make sure you check out passthemsra.com.
And for loads of great free learning materials and revision aids, don't forget freemsra.com. Good luck with the revision.